Ну, все готово.
Так, я переключаю, да? Угу. Меня уже слышно?
Да.
Good afternoon, dear students. Today we have a lecture, Management of Patients with Angina, Stable and Unstable, and Acute MI without complications. And according international classification of ischemic heart disease or coronary artery disease, all variants of ischemic heart disease includes sudden coronary death, angina pectoris, acute myocardial infarction, painless myocardial ischemia, heart failure, and disturbances of rhythm and conductivity. If you remember, coronary arteries supply blood to the heart muscles, and the right coronary artery supplies both the left and the right heart. The left coronary artery supplies the left heart. Ischemic heart disease or coronary artery disease is the most common form of the heart disease and the single most important cause of premature death in Europe, Russia, North and South America, Australia, and New Zealand. By 2020, it's estimated that it will be the major cause of death in all regions of the world. And ischemic heart disease or coronary artery disease, it's heart disease due to imbalance between myocardial oxygen supply and demand, which associated with atherosclerosis of coronary arteries in 95 to 96% of all cases. In development of the coronary artery disease occur risk factors and non-modifiable, uncontrolled, and modifiable, controlled risk factors. Non-modifiable risk factors include age more than 45, male gender, family history, genetic predisposition, and modifiable risk factors includes dyslipidemia at first, arterial hypertension, smoking, diabetes mellitus, obesity, fatty food diet, physical inactivity, stress, and hyperestrogenemia in female. And three major modifiable risk factors: dyslipidemia, arterial hypertension, and smoking. Coronary artery disease or ischemic heart disease includes at first stable variants or chronic coronary syndromes such as angina pectoris. And angina pectoris is a clinical syndrome caused by transient myocardial ischemia and may occur whenever there is an imbalance between myocardial oxygen supply and demand. Angina pectoris is a medical term used to describe chest pain caused by poor blood flow to certain areas of the heart muscle. Often the name is shortened to angina. Angina is a typical clinical syndrome, type of chest pain, pressing or burning, chest discomfort due to narrow of coronary artery. Heart is not receiving enough oxygen due to narrow coronary artery. Etiology of ischemic heart disease. In first place, coronary artery atherosclerosis. Except atherosclerosis, in the development of ischemic heart disease, should be coronary spasm, and sometimes also called variable angina, Prinzmetal angina. Variant angina typically occurs when the patient at rest, but in as many as 95–96% of all cases, at least blood vessel of heart has severe coronary blockage. Critical blockage of an coronary artery from atherosclerotic plaque build up when cholesterol or blood fats are too high, or patient has other risk factors. Fat-like material called atherosclerotic plaque builds up in blood vessels. Eventually, the plaque will block blood flow through the vessels. And first clinical signs of angina appears if coronary arteries narrow or more than 70%, obstructive type of coronary vessels. Exercise and emotional stress, the same, can cause angina. Microvascular dysfunction, the same, can cause ischemic heart disease and angina. And ischemic disbalance, discrepancy between demand and supply of myocardial oxygen. And the main reason of coronary artery disease, atherosclerosis of coronary arteries due to formation of atherosclerotic plaque. And if atherosclerotic plaque causes narrow of coronary arteries more than 70%, appears first clinical manifestation of ischemic heart disease. Except ischemic heart disease, except coronarogenic diseases, except atherosclerosis of coronary arteries, some diseases can cause angina. At first, arterial hypertension, aortic stenosis, hypertrophic cardiomyopathy, non-coronarogenic diseases, dilated cardiomyopathy, and in these cases, and in all cases, in paroxysmal tachyarrhythmias, in anemias, hypoxemia, in thyrotoxicosis, occur ischemic disbalance between oxygen supply and demand. In the development of ischemic heart disease occur ischemic cascade, which include some points. First point, the discrepancy between the demand and delivery of oxygen. Second point, myocardial ischemia, and this process can lead to reduced pH and the yield of potassium of cardiomyocytes, and increased intracellular calcium. Then develops regional left ventricle contractility violation, and appears signs of global systolic and diastolic dysfunction. After that appears ST segment changes and clinical manifestation, development of pain attack. Incidence of angina continuously rises with age in women, while in men the incidence of angina peaks between 55 and 65 years of age before declining. Also, angina pectoris is of great interest. There is a lack of data on a community-wide basis because it's very difficult to study. Many cases are undetected, and it's very likely that only a small fraction of cases rich specialist clinics. And angina pectoris, coronarogenic chest pain, characterized by some specific signs and criteria. And for characteristics of angina, we must give a characteristic for all criteria such as location, radiation, character, duration, precipitation, and relieving factors. And usually angina pectoris characterized by central diffuse pain and which radiate to jaw, neck, shoulder, arm, or back. On character, usually pressing, burning, squeezing pain. And on duration, usually 3 to 5 minutes, and in all cases less than 15 minutes. And provoking factors, exertion or emotional stress. And relieving factors, rest and nitroglycerin, short-acting nitroglycerin, and quick response to nitrates. Sometimes occur associated features such as breathlessness. Signs and symptoms: uncomfortable pressure, foulness, squeezing pain in the center of the chest, pain spreading to shoulders, neck or arms, and it may feel like pressure, tightness, or heavy weight, like elephant on chest. It may be located in the chest, upper abdomen, back, neck, jaw, or inside arm or shoulders. Depends on specific or typical or atypical variants. Typical variants are usually characterized by central diffuse substernal chest pain. Except pain may be anxiety, neurosis, sweating, nausea, dyspnea, and maybe tachycardia, painless variant should be sometimes. Chest pain may be caused by insufficient blood flow from partial blockage of the coronary artery due to obstruction of coronary artery of atherosclerotic plaque. And stable angina is a clinical syndrome, is a repeating pattern of the chest pain, which has not changed in character, frequency, intensity, or duration for several weeks. The level of activity or stress that provokes angina is predictable and the pattern changes slowly. Stable angina is the most common form and it appears gradually. These patients have an increased risk of heart attack, but an episode of stable angina does not indicate that a heart attack is about to happen. Crucial component of the management of the pain associated with angina pectoris is identifying sources of stress and creating effective methods to minimize stress. And stable angina, according to Canadian Cardiovascular Society, divided on 4 functional classes. Functional classification of stable angina include at first class, no limitation of ordinary activity. Walking or climbing stairs does not cause angina. Angina may occur with unusual, strenuous, rapid or prolonged exertion. Second class, slight limitation of ordinary activity. Angina may occur with walking or climbing stairs rapidly and or walking more than 200 meters or climbing more than one flight of stairs at a normal pace and in normal condition. Third class, marked limitation of ordinary activity. Angina may occur after walking from 100 to 200 meters or climbing one flight of stairs at a normal pace and in normal condition. And fourth class, unable to carry on any physical activity without chest discomfort. Any level of physical exertion can cause angina, and angina may occur after walking less than 100 meters, may be present at rest. Unstable angina. Unstable angina is a chest pain that is variable, either increasing in frequency or intensity and with irregular timing or duration. Unlike stable angina, unstable angina does not appear gradually. It first appears as a severe episode. An established stable angina might change suddenly or be provoked by less stress than in the past, or an episode might suddenly occur while at rest. If the pattern of an episode changes, for example, if a previous episode was only brought on duration physical exertion, but an episode suddenly occurred at rest, it's likely to be unstable angina. Unstable angina includes some variants. At first, new onset angina, from first clinical signs of substernal angina pain, anginal pain or chest discomfort till 28 days. Progressive angina patterns, increase intensity and duration of pain, increase quantity of attacks, appearance angina at rest and or at night, increased class of angina, progressive decreased tolerance to physical exertion, and transient ischemic changes on ECG at rest. Third variant of unstable angina, early post-myocardial infarction angina, from 3 to 28 days. And fourth variant, angina at rest. How we are distinguish stable and unstable angina? In stable angina usually occur fixed stenosis of coronary arteries. In unstable angina, as a variant of acute coronary syndrome, occur dynamic stenosis due to spasm or due to rupture of atherosclerotic plaque and formation of thrombus. And in stable angina, demand lead ischemia. In unstable, supply lead ischemia. And in stable angina, related to effort and unstable angina, symptoms may be at rest. Stable angina, predictable, unstable, unpredictable. Stable angina, symptoms occur over long term. In unstable, symptoms over short term. In stable angina, symptoms on minimal exertion sometimes, and in unstable, frequent or nocturnal symptoms. Exercise testing should be positive in stable angina. Exercise depends on physical activity, depends on degree of ECG changes. And in unstable angina, ECG changes is characterized by these clinical symptoms. And one of the variant of angina, Prinzmetal angina, it's spontaneous or angiospastic or vasospastic angina caused by vasospasm and spasms that narrows the coronary artery and lessens the blood flow to the heart. Prinzmetal angina usually occurs in arteries already narrowed by atherosclerosis. In fact, most people with it have severe coronary atherosclerosis in at least one major vessel. Spasm usually occurs very close to the blockage. Unlike stable and unstable angina, Prinzmetal angina usually occurs when a person at rest or sleep, often at night before morning, and not after physical exertion or emotional stress. It's associated with acute myocardial infarction, severe cardiac arrhythmias, including ventricular tachycardia and fibrillation, and sudden cardiac death. Microvascular angina or stable angina patterns on angiographically intact vessels, or another name, coronary syndrome X. Microvascular angina or syndrome X occurs not same with acute coronary syndrome. And microvascular angina occurs when the patient experiences chest pain but has no apparent coronary artery blockade. This condition results from poor functioning of the teeny blood vessels that nourish the heart, arms, and legs. Microvascular angina can occur during exercise or at rest. Reduced vasodilator capacity of the coronary microvessels is thought to be a cause of angina during exercise, but the mechanism of angina at rest is not known. Coronary microvascular spasm resultant myocardial ischemia may be the cause of chest pain in a subgroup of patients with microvascular angina. Coronary syndrome X characterized by three specific typical signs. At first, classic angina, and second criteria, ST segment depression on ECG during stress test, and third criteria, angiographically normal coronary arteries without left ventricle dysfunction. Investigations in ischemic heart disease includes laboratory and instrumental methods. Laboratory investigation include CBC, at first hemoglobin, for excluding anemia and ischemic disbalance due to anemia, and lipid profile, total cholesterol, high density cholesterol level, low density cholesterol level, triglycerides, glucose, AST, ALT, creatinine for calculation of GFR, glomerular filtration rate, and additional indicators such as cardiac troponins if we are suspect about acute coronary syndrome for differential diagnosis, And thyroid function the same for differential diagnosis if we are suspect about thyrotoxicosis. Laboratory and instrumental methods include resting ECG, reversible ST depression or elevation on ECG with or without T wave inversion at the time the patient is experiencing symptoms. But sometimes and usually we have no changes on ECG at rest without attack, without clinical signs of angina. Exercise ECG, standard treadmill or bicycle protocol, and planar or downsloping ST depression of 1 millimeter or more is indicate of ischemia. Holter monitoring ECG during 24 hours can reveal a painless variant of ischemic heart disease. Myocardial perfusion scanning, helpful in patients who are unable to exercise. Its predictive accuracy is higher than that of the exercise ECG. Stress echocardiography to identify ischemic segments of myocardium and areas of infarction, inhibit reversible defects in contractility during exercise or pharmacological stress with dobutamine. And the gold standard of diagnosis in ischemic heart disease and coronary artery disease, coronary arteriography, provides detailed anatomical information about the extent and nature of coronary artery disease and is usually performed with a view to coronary bypass grafting or percutaneous coronary intervention. May be indicated when non-invasive tests have failed to elucidate the cause of atypical chest pain. On ECG, you can see ST elevation in first limb lead, AVL, and in chest leads from V2 to V5. It's typically for acute ST elevated MI of anterior wall, septum, apex, and lateral wall, extensive MI. And in V3 R wave absent. It's characterized by the appearance of QS wave for transmural MI. It's criteria of transmural MI. Management of stable angina. Management of angina pectoris involves careful assessment of the likely extent and severity of ischemic heart disease, the identification and control of significant risk factors, the use of measures to control symptoms, the identification of high-risk patients, and application of treatments to improve life expectancy. Methods of treatment of stable angina include non-pharmacological therapy, pharmacological therapy, and surgical treatment, invasive strategy. Non-pharmacological therapy include lifestyle modification and elimination of risk factors of coronary artery disease, cardiovascular disease. Controlling the risk factors for angina, such as high blood pressure, cigarette smoking, high cholesterol level, and excess weight is an essential part of treatment. And antiplatelet therapy, low dose aspirin, 75 to 100 milligram usually, reduces the risk of adverse events such as myocardial infarction and should be prescribed for all patients. Clopidogrel, 75 milligram, is an equally effective agent that can be prescribed if aspirin causes dyspepsia or other side effects, and if aspirin contraindicated in peptic ulcer, for example. And medical management of patients with coronary artery disease, with angina, divided on two ways. First direction, angina relief, and second direction, event prevention. Angina relief includes first line and short-acting nitrates, nitroglycerin sublingually, or isocat spray, plus anti-ischemic therapy for prevention of further angina attack. And first line anti-ischemic drugs include beta blockers or calcium channel blockers, which decrease heart rate if beta blocker indicated or intolerance. And consider calcium channel blockers dehydropyridine origin if occur low heart rate or intolerance or contraindications to beta blockers or calcium channel blockers, verapamil and diltiazem, non-dehydropyridine origin. And if, according to Canadian Cardiovascular Society, angina more than second functional class, we consider combination beta blockers plus calcium channel blockers dehydropyridine origin. And if no effect after usage of two anti-ischemic drugs, we used second line, may add or switch first line for some cases, and can add ivabradine or long-acting nitrates or nicorandil or ranolazine or trimetazidine. And if 3 or 4 anti-ischemic drugs have no effect, in this case we consider coronary angiography and percutaneous coronary intervention, usually stenting if 3 coronary artery affected or more than 50% of left coronary artery obstruction. We consider CABG, coronary artery bypass graft. For event prevention, we use non-pharmacological methods of management, lifestyle modification and control of risk factors with education of patient, and drugs which improve prognosis, aspirin, antiplatelets or clopidogrel, statins, and consider AC inhibitors or angiotensin II receptor blockers if AC inhibitors intolerance or contraindications. Nitroglycerin is a drug most often used. It mainly relaxes the veins and relaxes the coronary arteries a little. By relaxing the veins, peripheral vasodilator it reduces the amount of blood that returns to the heart and eases the heart workload. By relaxing the coronary arteries, it increases the heart blood supply. The heart's demand for oxygen also can be modified with drugs that reduce blood pressure. This reduces the heart workload and needs for oxygen. Drugs that slow the heart rate have a similar effect. Drugs called beta blockers and calcium channel blockers are used for this effect. There are many different beta blockers and calcium antagonists, and the specific ones used are selected depending on the individual characteristics of each patient. For angina relief, I repeat, first line beta blockers such as metoprolol, cardioselective drugs, bisoprolol, nebivolol, carvedilol, and calcium antagonists such as dihydropyridine origin amlodipine and non-dihydropyridine origin verapamil and diltiazem, which decrease heart rate. Calcium channel blockers usually we use if occur intolerance to beta blockers or in combination if angina pectoris more than second functional class, according to Canadian Cardiovascular Society. And second line of management, ivabradine, 5 mg or 7.5 mg twice daily. And ivabradine, its mechanism of action include no action on blood pressure, only decrease heart rate. And indication for ivabradine, it's heart rate more than 70 and sinus rhythm. Long-acting nitrates, such as isosorbita dinitrate or isosorbita mononitrate. And nicorandil, and combination of potassium channel activators and nitrates, gibrit. Nicorandil can use 10 or 20 mg twice daily. Ranolazine, 500 or 1000 mg twice daily. Sodium channel blocker. And trimetazidine. Usually 80 mg once daily. Cardiometabolite. Anti-ischemic therapy include 4 groups of drugs: nitrates, beta blockers, nitrates, calcium channel blockers, and potassium channel activators like nicorandil. Drugs which improve prognosis. At first, antiplatelets, aspirin and clopidogrel. And hyperlipidemic drugs, at first statins. And lovastatin, simvastatin, atorvastatin, rosuvastatin, and now we are used atorvastatin and rosuvastatin. Beta blockers, atenolol, metoprolol, bisoprolol, nebivolol, carvedilol. Same drug which improve prognosis. And AC inhibitors, drugs for prevention of heart muscle remodulation. Enalapril, lisinopril, perindopril, ramipril can use. Cardiometabolic therapy. Trimetazidine, ribaxin, mildronate. vitamins and antioxidants can use. And pharmacological management will depend on severity of symptoms and severity of underlying disease and extent of damage to the heart muscle, if any. Simple rest or observation and aspirin, breathing oxygen and sublingual nitroglycerin may be all the patient needs. If it is only angina, you may be given medication to reduce anxiety or to treat pain. And except pharmacological management can use invasive strategy. Invasive techniques that improve the heart and the heart's blood supply also may be used. One of these percutaneous coronary intervention or percutaneous transluminal coronary angioplasty. And in it, thin flexible plastic tube catheter with a balloon is inserted into an artery and advanced to the blockage. Then the balloon is inflated, squeezing open the fatty plaque deposit, and then the balloon is deflated, and the catheter is withdrawn. Often a stent is also placed to hold the artery open. Two additional techniques used to reduce coronary blockage are laser angioplasty and atherectomy. In laser angioplasty, a catheter ectomy with a laser on its tip is used to open the blockage. In atherectomy, a catheter has a rotating shaver on its tip to cut away the plaque. These techniques also may be accompanied by stent placement. And now we use usually stent placement. And for prevention of rupture of coronary vessels, balloon angioplasty, and now we use very rare. Invasive and except PCI, coronary percutaneous coronary intervention, can use coronary artery bypass graft surgery. In it, a blood vessel is used to roll blood around the blockade part of the artery, forming a kind of detour. Before performing any of these procedures, a doctor must find the blocked parts of the coronary arteries. This requires coronary arteriography, which is done during cardiac catheterization. In this procedure, a doctor guides a catheter through an artery in the arm or leg into coronary arteries. Then the doctor injects a liquid D through the catheter. High-speed X-ray records the course of the D as it flows through the artery. Doctors can identify blockages by tracking the flow. An evaluation of how the heart works also can be done during cardiac catheterization. Other tests can be used to evaluate how well the heart works and may be done before or after a heart attack. Before angioplasty, before invasive strategy can be done, the areas of coronary artery nerving is located with coronary arteriography. And next part of our lecture, acute coronary syndrome. What does it mean, acute coronary syndrome? Is acute coronary insufficiency. It's preliminary diagnosis. And definition of acute coronary syndrome as a group of symptoms and signs allowing to suspect acute myocardial infarction or unstable angina. Acute impairment of coronary blood flow, acute coronary insufficiency. And acute coronary syndrome occur during 24 hours because it's preliminary diagnosis. And diagnosis made when a physician sees a patient for the first time in order to choose proper management. And destabilization of atherosclerotic plaque can lead to thrombosis of coronary arteries and spasm and considerable constriction. Acute coronary syndrome should be two variants: ST elevation acute coronary syndrome and non-ST elevation acute coronary syndrome. ST elevation acute coronary syndrome include Q-wave acute MI and non-Q-wave acute MI. And non-ST elevation acute coronary syndrome include unstable angina and Q-wave acute MI and non-Q-wave acute MI. I repeat, unstable angina, it's acute myocardial ischemia, severity and duration of which is not sufficient for development of acute myocardial necrosis. And unstable angina includes new onset angina till 28 days, progressing angina, and early post-MI angina from 3 to 28 days. Unstable angina, exacerbation of ischemic heart disease, manifested by development of changes in the character of pain, longer and more frequent attacks, less tolerance to physical activity, more tablets of nitroglycerin taken. Acute myocardial infarction. Acute myocardial infarction is an acute ischemic necrosis of myocardium of any mass. Keywords: ischemic necrosis and non-ST elevation and non-Q-wave acute MI differs from unstable angina in an elevated level of biochemical markers of necrosis, cardiac troponins. At first, according to last definition of myocardial infarction, clinical definition of myocardial infarction denotes presence of acute myocardial injury detected by abnormal cardiac biomarkers in the setting of evidence of acute myocardial ischemia. Now we use classification of acute MI according to types. Type 1, spontaneous acute MI, which characterized by sudden appearance of severe intensive substernal chest pain due to plaque rupture, due to erosion, ulceration, and formation of thrombus, obstruction of coronary artery. acute ischemia appears due to acute ischemic necrosis appears due to complete obstruction of coronary artery. Type 2, infarction secondary to oxygen supply and demand imbalance due to spasm, endothelial dysfunction, due to left ventricle hypertrophy, due to anemia, hypoxemia, arrhythmias, hypotension, and cocaine intoxication. Type 3, cardiac arrest, sudden death, no biochemical markers assays. Type 4 divided on 3 subgroups. 4A, infarction secondary due to percutaneous coronary intervention. Type 4B, infarction secondary to stent thrombosis. And type 4C, infarction due to restenosis after PCI. And type 5, infarction secondary due to CABG, coronary artery bypass graft. Usually, most often, acute MI is characterized by classical angina pain behind the breastbone, more than 20 minutes, which becomes more intensive and unusual and is not controlled with nitroglycerin. And typical variants of progressing prolonged more than 20 minutes angina pain at rest, development of severe angina not lower than third functional class for the first time in life, advancing of angina and increase in its functional class, not lower than third functional class. Typical variants of progressing angina. It's criteria of progressive angina. And atypical variants of progressing should be severe pain in epigastrium, gastric form, abdominal variant, and acute indigestion, throbbing pain in the chest, pleural pain, increasing dyspnea. And atypical variants of MI occur in 4 main categories, such as younger patients till 40, older patients more than 70, in females, and in diabetics. Diagnosis of acute MI based on analysis of clinical manifestation, ECG, and biochemical markers of necrosis. ECG should be taken within the first 10 minutes since a physician sees a patient and is repeated 6, 12, 24 hours later. If necessary and maybe fast, maybe. Yeah. The level of troponin T and I should be determined within 60 minutes since admission to hospital and is repeated 6, 12, and 24 hours later in case of negative first result. Algorithm of diagnosis of acute MI include three main parameters: clinical manifestation, ECG, and biochemical markers. If we reveal angina pain more than 20 minutes, can do ECG. If ST elevation, we reveal acute MI. No ST elevation, can be acute MI or unstable angina. And biochemical markers of necrosis at first: troponin T or troponin I, and creatine kinase, and myoglobin. Can do AST, can do LDH. Increasing number of markers, typically for MI. No increasing number of markers, unstable angina. Sorry. ECG in non-ST elevation acute MI, abrupt ST segment depression and or T-wave inversion of more than 1 mm in two or more adjacent leads. Maybe signs of bundle branch blocks. Normal ECG in case of persistent, unusual severe attack of angina does not exclude acute coronary syndrome. Management of patients with acute coronary syndrome. Term acute coronary syndrome was introduced into clinical practice in order to apply active methods of treatment with early revascularization. Thrombolytic therapy, even before diagnosis of acute myocardial infarction, is confirmed. It has been determined that method of emergency treatment depends on the position of ST segment relative to the isoelectric line of the ECG. If ST segment is above the isoelectric line, thrombolytic therapy is effective and indicated. But if there is no ST elevation, such therapy is not effective and not indicated. Management of patients with non-ST elevation acute MI in the pre-hospital setting. At first, calling an ambulance. If clinical death, we can do CPR to calm down, to provide fresh air, to sit, and nitroglycerin at first, 0.5 milligrams sublingually, tablets 1 to 3 times every 3 to 5 minutes, with BP control and pulse rate. Aspirin, dual antiplatelet therapy, 150 to 300 milligram, and clopidogrel, first dose 300 milligram, and maintenance dose 75 milligram per day. Inspection and physical examination, taking ECG, decision as to admission to hospital, to the intensive care unit, or to emergency department. Treatment of non-ST elevation acute MI. At first, after nitroglycerin, antithrombotic drugs, acetylsalicylic acid, 150 to 300 milligram first dose, and then 75 to 100 milligram per day, plus clopidogrel 300 to 600 milligram as a first dose, and then 75 milligram per day. Dual antiplatelet therapy till 70 years. After 70 years, first dose must be acetylsalicylic acid 100 milligram and clopidogrel 75 milligram for prevention of hemorrhage in older patients. Low doses of dual antiplatelet therapy. Anticoagulants, unfractionated heparin. For at first 60 units per kilogram as intravenous bolus up to 4,000 units, then 12 units per kilogram per hour as intravenous infusion up to 1,000 units per hour under the control of APPT, activated partial prothrombin time, 1.5 to 2 times higher than normal. Normal range 30 to 35, and our main goal increase to 50 to 70 seconds. Low molecular weight heparins or fondaparinux better than unfractionated heparin because less adverse effects. Fondaparinux 2.5 mg subcutaneous once per day, enoxaparin first dose 30 mg intravenous bolus, and then 1 mg per kilogram subcutaneous every 12 hours. Can use dalteparin or nadraparin. Usually in non-ST elevation MI, duration of anticoagulant therapy 2 to 5 days. Anti-ischemic therapy include the beta blockers, cardio-selective, and long-acting nitrates, and calcium channel blockers. Verapamil-diltiazem if beta blockers contraindicated, or calcium channel blockers with hydropyridine origin if bradycardia or add to beta blockers. Statins, atorvastatin, rosuvastatin, and ACE inhibitors for all patients for prevention of remodulation of myocardium. If ACE inhibitors intolerance, angiotensin 2 receptor blockers. And can use non-narcotic and narcotic analgesics if effect of short-acting nitrates is not sufficient. And symptomatic therapy, hypotensive, antiarrhythmic drugs, surgical myocardial revascularization. Indications and choice of method of revascularization are determined by the character of coronary artery impairment based on coronary ventriculography. ST elevation acute coronary syndrome. ST elevation is a manifestation of transmural myocardial ischemia, which occurs due to complete occlusion of more of major coronary arteries and results in acute MI development. Thus, the key difference in management of patients with ST elevation acute MI is administration of thrombolysis for early myocardial reperfusion. Acute MI is acute coronary syndrome caused by sudden stoppage of coronary blood flow due to atheromatous plaque rupture and thrombosis of coronary artery, leading to ischemic necrosis of myocardium. Usually, clinical manifestation of ST elevation acute MI characterized by sudden intensive pain behind the sternum, unexpected, unusual, persistent, more than 20 minutes pain, severe pain, pain which not controlled by nitroglycerin, sudden worsening of condition, and patients are anxious, experiencing fear of death, and on physical examination can reveal pale skin, cyanosis, tachycardia, arrhythmia, galloprythm, decreased blood pressure. Usually in our practice occur ungenous variant, typical variant of acute MI in 70 to 90% of all cases, and atypical variants include asthmatic variant, cardiac asthma and pulmonary edema, like type 10% of all cases, abdominal variant, which characterized by pain in abdominal area and dyspepsia, arrhythmic variant, sudden development of impaired rhythm and conductivity, cerebrovascular variant, characterized by loss of consciousness, acute impairment of cerebral blood flow, acute MI with atypical pain, maybe pain in jaw, back, arm, right side, chest pain, and painless variant of acute MI diagnosed by ECG. I repeat, 4 categories suffered from atypical variants: asthmatic, abdominal, arrhythmic, cerebrovascular, painless, and with atypical pain. Younger patients till 40, older patients more than 70, females, and diabetics. Diagnostic criteria of acute MI include sudden, severe, intensive, unusual, persistent, more than 20 minutes pain behind the sternum, not relieved by nitroglycerin, often accompanied with fall in blood pressure, and should be acute considerable worsening in the condition of a seriously ill patient accompanied with fall in BP. Sudden development of severe impairment of rhythm or acute left ventricle failure. Acute development of left bundle branch block and right bundle branch block the same. Typical ECG changes include ECG should be taken within first 10 minutes after admission and then 6, 12, 24 hours later on the first day, and ST elevation more than 1 mm in standard leads and or more than 2 mm in chest leads, once with characteristics dynamics. Pathological appearance of pathological Q wave, more than 25% of R wave amplitude and more than 0.03 seconds on duration, appearance of negative T wave, on this ECG we can see ST elevation in first limb and in V1, V2, V3, V4 and V5. Extensive acute anterior ST elevation, MI, extensive anterior MI. And this formation of QS wave in V3, V4, R wave absent, it's transmural MI of septum and apex. ECG dynamics in acute MI include some periods. First period, acute ischemia with duration from 15 to 30 minutes and characterized by increased voltage of T wave, more than 50% of R. Then acute ischemia change on damage of myocardium, appears ST elevation, duration of this period should be acute period from some hours till some days, usually 7 to 10 days, and then period of necrosis, appearance of pathological Q wave, decrease voltage of R, decrease ST segment, formation of negative T, and appearance of pathological Q, all characteristics of acute period of MI with duration from some hours till 7 to 10 days. Then gradually ST segment come back to isoline, and when ST segment on isoline, it's typically for subacute period. And last period, fibrosis, formation of scar. Basic therapy of in ST elevation acute MI include some principles, and at first, pain relief. Usually morphine, nitroglycerin. At first we can give on pre-hospital stage nitroglycerin sublingually 1 to 3 times every 3 to 5 minutes. But if not effect, can use morphine 1%, 1 milliliters on 10 milliliters of saline, and 4 to 6 milligram intravenous, and if no effect, every 10 to 15 minutes repeat. Oxygen therapy through the mask or nasal catheter, 2 to 4 liters per minute, and reperfusion therapy. Before reperfusion therapy, before thrombolysis, before choosing of method of reperfusion therapy, we must give anticoagulant therapy, unfractionated heparin or low molecular weight heparin or fondaparinux. And after nitroglycerin on pre-hospital stage, antithrombotic dual antiplatelets. Dual antiplatelet therapy, aspirin plus clopidogrel or prasugrel or ticagrelor, or depends on further our tactics. If we choose invasive strategy, better aspirin plus prasugrel or ticagrelor. If we use conservative strategy, pharmacological management, usually we use aspirin plus clopidogrel. Anti-ischemic therapy, beta blockers to all patients who have no contraindications, nitrates at first on pre-hospital stage, short-acting nitroglycerin, and if no effect, after nitroglycerin, after morphine, can use nitroglycerin intravenously, isocate 0.1%, 10 milliliters, with 200 milliliters saline for intravenous drops. And drugs which improve prognosis, statins and ACE inhibitors to all patients who have no contraindications. And in this table you can see our strategy. It depends on total ischemic time. If time to PCI less than 120 minutes, our tactics include invasive strategy, primary PCI strategy, reperfusion via crossing. And if time to PCI consists of more than 120 minutes, we use fibrinolysis, lytic bolus. And important time targets. Maximum time from first medical contact to ECG and diagnosis, less than 10 minutes. Maximum expected delay from ST elevated acute MI diagnosis to primary percutaneous coronary intervention via crossing, to choose primary PCI strategy over fibrinolysis. If this target time cannot be met, consider fibrinolysis, less than 120 minutes. Maximum time from ST elevation MI diagnosis to via crossing in patients presenting at primary PCI hospitals, less than 60 minutes or same. Maximum time from ST elevation MI diagnosis to via crossing in transferred patient, less than 90 minutes or same. Maximum time from ST elevation MI diagnosis to bolus or infusion start of fibrinolysis in patients unable to meet primary PCI target times, less than 10 minutes or same. Time delay from start of fibrinolysis to evaluation of its efficiency, success of failure, 60 to 90 minutes. Time delay from start of fibrinolysis to angiography, if fibrinolysis is successful, from 2 to 24 hours. Indications for thrombolysis: acute myocardial infarction with Q wave and ST elevation of 1 and more millimeters in 2 adjacent leads on ECG and up to 6 hours ago. Acute, second indication, acute MI with Q wave and ST elevation of 1 and more millimeters in 2 adjacent leads on ECG and up to 12 hours ago if the pain persists. Third indication, no contraindications. And fourth indication, agreement Patient's agreement, consent. And the main thrombolytics we use usually streptokinase, alteplase, and tenecteplase. Beta tenecteplase because intravenous bolus within 10 seconds usage allowed in the pre-hospital setting. From 30 to 50 milligram, depends on body weight. And alteplase, human tissue plasminogen activator, recombinant, in 90 minutes regimen can use 15 milligram as intravenous bolus, and then second dose 0.75 milligram per kilogram body weight for 30 minutes, 50 milligram intravenous drops, and then 0.5 milligram per kilogram body weight, 35 milligram usually during 60 minutes intravenous drops. Not more than 100 milligram. Streptokinase 1.5 million units per 1000 milliliters of saline solution intravenous drops during 30 to 60 minutes. Time of introduction optimally within first 2 to 3 hours, later worse prognosis. Fibrinolysis should be performed as soon as possible within 90 minutes from a call to introduction. Within 30 minutes after admission to hospital, thrombolysis is not performed if acute MI developed more than 12 hours ago. Absolute contraindications to thrombolysis: previous history of hemorrhagic stroke. Second, history of ischemic stroke within 6 months. Intracranial neoplasm. Major head trauma. Injury or surgery within 3 months. Bleeding within 1 month. Aortic dissection. Criteria for efficiency of thrombolysis. First, restored patency of coronary artery by findings of coronary angiography. Pain relief within 30 to 60 minutes after introduction of thrombolytic. More than 50% reduction in ST segment level in comparison with the initial ST segment level. Bradyarrhythmias in posterior acute MI. Sudden increase of enzymes activity by more than twice. And reperfusion arrhythmias. Percutaneous coronary intervention. It's a method better than thrombolytics and for restoration of coronary circulation. And but indications for PCI and we use PCI depends on time of appearance of acute MI and location of PCI center. And last guidelines according to myocardial infarction: myocardial injury and myocardial infarction. Myocardial injury is defined by the presence of cardiac troponin values above the 99th percentile of the upper reference limit. Myocardial injury may be acute, rise and or fall of troponin values, as in acute heart failure, or chronic, as in chronic kidney disease. Myocardial injury may occur in a variety of situations, including after coronary procedures, intervention, and or with cardiovascular and non-cardiovascular illnesses. Occurrence of acute myocardial injury in the setting of acute myocardial ischemia defines acute myocardial infarction. Myocardial infarction type 1 is acute myocardial injury related to acute atherothrombotic coronary artery disease. It's usually precipitated by atherosclerotic plaque disruption that reduced blood supply to the myocardium. Myocardial infarction type 2 is acute myocardial injury related to an imbalance between myocardial oxygen supply and demand secondary to stressors unrelated to acute coronary artery thrombosis. Myocardial infarction type 3 is related to patients who suffer cardiac death with symptoms suggestive of acute myocardial ischemia accompanied by new ischemic ECG changes and die before biomarker value could be obtained. Myocardial infarction type 4A denotes PCI-related increases of troponin's value more than 5 times the 99th percentile from a normal of, or if elevated, stable pre-procedural baseline. New myocardial ischemia evidenced by ECG or imaging or complications leading to reduced coronary blood flow are required. Myocardial infarction type 4B is acute myocardial ischemic injury related to stent thrombosis, and myocardial infarction type 4C is acute myocardial ischemic injury associated with restenosis. Myocardial infarction type 5 is CABG-related increases of troponin values more than 10 times 99th percentile from a normal of, or if elevated, stable pre-procedural baseline. New myocardial ischemia or new loss of myocardial viability is required. Dear students, thank you for your attention. I wish you success.